Good afternoon, everybody. I'm very happy to share with you my opinion regarding allogenic hematopoietic cell transplantation and myelofibrosis. So first of all, I'd like to highlight that International Academy for Clinical Hematology webinars are something really outstanding, and I'm very happy to partake in this series of webinars. So, for those who don't know me, I'm Professor Ibrahim Yakoub Agha. I work at Lille University Hospital in France. Today, I would like to discuss with you allogenic hematopoietic cell transplantation in myelofibrosis. You know, I've been working in transplantation for many years, and I can tell you myelofibrosis as well as CMML are the two diseases that are very difficult to transplant. So today I will give you some insight how to manage those patients. So I start with my disclosure slide. Actually, I have nothing related to this presentation. Just some reminders regarding the incidence of myelofibrosis. As you can see here, if we focus on myeloproliferative neoplasm, so primary myelofibrosis, the incidence is the lowest incidence of them. And as you can see here with the range of estimated value, you know, myeloproliferative myelofibrosis account for a quarter of polycythemia vera, for instance, a third of essential thrombocythemia, and around 50% of CML. That's to say, this is really a rare disease, but it's really difficult to transplant, as I said. If we go for survival of those patients compared to general population matched for the age, for instance, you can see survival for patients with polycythemia vera, essential thrombocythemia, and for myelofibrosis, median survival, it's as low as 6 years. Now, what is myelofibrosis? I will try to simplify this disease. First of all, I know you know this, but it's easy to start like this. Everything starts with the fibrosis of bone marrow and other organs, by the way. And after this, we can see a splenomegaly. So we can observe patients with myelofibrosis without splenomegaly, and the majority of them develop splenomegaly for extramedullary metaplasia. This myelofibrosis splenomegaly can be responsible of cytopenias, especially anemia, and then constitutional symptoms. And the whole feature of the disease can be responsible for thrombotic and bleeding complications, infection, portal hypertension, pulmonary hypertension. This is important. You know, I will say some word about this, and risk of transformation into acute myeloid leukemia. So, in front of patient, for the first time you see a patient, you have some question. First of all, do I need to treat the patient? Otherwise, if yes, if so, what should it be? No transplant approaches or transplantation? Which factors help me to decide? If transplantation, who is a good candidate for transplantation? How to transplant and when? Let's start with the indication of transplantation. Actually, guys, if your patient has favorable physical conditions, has no symptoms, good appetite, stable weight, absence of problems with an enlarged spleen, and with the stable blood counts. So for me, there is no need to treatment. It's likely unnecessary to initiate a treatment. Actually, as a doctors, we treat patients, not figures or numbers. What would be the objective of the therapy in myelofibrosis? So We need to treat the anemia and other cytopenias when indicated, of course. Reduce symptomatic splenomegaly. Reduce constitutional symptoms such as weight loss, night sweats, fever, pruritus, and avoid first occurrence or recurrence of thrombotic and bleeding complications, which is very, very important in those patients. Manage risk situations because of thrombotic and bleeding complications, and minimize the risk of acute leukemia. And if we look at curing the patient, so cure is possible, which means allogeneic hematopoietic cell transplantation when indicated, because it's still the only curative option for those patients. What we have some available treatments outside allogeneic transplantation. Let's start with conventional non-JAK inhibitors. Before the era of JAK inhibitors, cytoreductive strategies. So to treat splenomegaly, we can use hydroxyurea, interferon gamma. For the cytopenias and anemia, we have transfusion, EPO, steroids, androgens, and for constitutional symptoms, so the steroids. We have nothing to reduce myelofibrosis. Then, after the advent of JAK inhibitors, first generation, ruxolitinib and beyond, so we know that all JAK inhibitors are effective against splenomegaly. So we can observe shrinking or reducing in the spleen volume in roughly a third of patients, 35% of patients. And there is a great effect on constitutional symptoms. As I always said, ruxolitinib, it's a very potent anti-inflammatory drug. However, with the first generation, especially with ruxolitinib, we have some side effects such as aggravating the anemia and cytopenias. Do we have benefits with JAK2 inhibitors? Yes, symptom relief, which is, I would say, the benefit number one, spleen shrinkage in 35% of patients, and prolonged survival. What about survival? Actually, in the first studies, we had to wait for almost 10 years before seeing a significant difference in survival for those patients with myelofibrosis. Now, which treatment? Actually, this slide is outside the topic of today's webinar because I want to focus on allogeneic transplantation. Anyway, so just as you can see here, when you are facing splenomegaly and constitutional symptoms, ruxolitinib is the first choice. When you are facing anemia, thrombocytopenia, we adapt the doses of ruxolitinib with massive splenomegaly, thrombocytopenia. So ruxolitinib, it's difficult to manage there. Or fedratinib can be used, the second generation of JAK inhibitors. Anemia, we can use erythropoietin, danazol, imides, corticosteroids, thrombocytopenia, androgens, imide, corticosteroids. Also, proliferation. So when you have a lot of white blood cells, you can look at the interferon pegylated. We can do association, of course, ruxofedratinib. When we have cytopenias, we can add erythropoietin, danazol, imide, steroids, etc. Ruxolitinib with interferon, for instance. And we have a lot of treatments under investigation nowadays. Drugs that targeting apoptosis, epigenetic modification, signaling pathways, bone marrow fibrosis, which is something important for us. As I mentioned, it's very difficult to get rid of bone marrow fibrosis in those patients. We can target telomerase, nuclear transport, CD123, and erythroid maturation, lutacetercept, which is use it for myelodysplastic syndrome and can be used here. And as you can see here, if you go to clinicaltrial.gov, you can see many ongoing studies all around the world focusing on patients who are JAK inhibitor naive, or following first-line JAK inhibitor exposure or failure. Perspective for the anemia, we have memolertinib, luspatercept can be associated with roxo, thrombocytopenia, pacritinib, proliferation, high risk, navitoclax, and etc. So my first message will be this. In the present day or nowadays, there is a growing array of medications available for managing patients with myelofibrosis. There is a hope. Now, what about transplantation? If we look at the EBMT statistic, we can see in 2021, 4% of patients were transplanted for myeloproliferative neoplasm. The vast majority of them were transplanted for myelofibrosis. At the Chronic Malignancies Working Party, we worked on the incidence or transplantation in myelofibrosis. As you can see here, in 1995, there were few patients transplanted, and the number has been increasing over time. So we observed increased activity from less than 100 patients a year in Europe for more than 500 a year, with increased recipient age by 10 years. And we started using a related donor and recipient Karnofsky index less than 90. That's to say, patients with less fitness, I would say, for transplantation. We observed decreased usage for myeloablative conditioning, which is normal because in elderly and old patients, we cannot use MAC, and patients with comorbidities, and the increased use of busulfan-based platform and antithemoglobulin. In multivariate analysis, we demonstrated improvement in overall survival, despite and reduction in the relapse risk, despite the fact that the median age is increasing and Karnofsky going down, etc. That's to say, we start improving the allogeneic transplantation in those patients. So which factors help us to make a decision? Actually, the decision of transplant in myelofibrosis is a real delicate balancing act. This is not easy. That's why we try to make it easier, I would say. This work with Juan Carlos Hernandez Boluda with the Chronic Malignancies Working Party. So we can see here, there are factors to be taken into account when we decide for transplantation or not. First of all, patient physical condition, pre-transplant preparation, disease-related feature, transplant factors, etc. So let's go through these factors. First of all, so patient-related factors, advanced age. The median age of myelofibrosis is something like 67 years old. So this is really a disease for old patients or elderly. We consider 70 years as a cutoff, and transplantation below 70, it's something reasonable. So you have patients with advanced age more than 70 or 75 in some centers if you want. So it's not good for transplantation. When you have poor performance status, it's not good for transplantation. Prohibitive comorbidities, this is very important too. So you need to assess, to evaluate the condition of your patients, and severe complication related to myelofibrosis, such as iron overload, life-threatening condition hemorrhage, uncontrolled infection, etc. If you don't have these factors, so you can go to transplantation. I would like to highlight the pulmonary hypertension. This is a complication to myelofibrosis. You need to look at it before transplantation. As you can see here, patients with pulmonary hypertension, they have higher non-relapse mortality and shorter overall survival. So this is very important to assess before deciding for transplantation for those patients. Of course, you need to look at the heart, kidney, liver, etc. Now, what about disease-related factors? So you need to know and to ask the question, is there a risk or high risk to transformation into acute myeloid leukemia? If yes, I think transplantation would be indicated here because there is no other treatment to prevent this transformation. How to decide? So if you go to the old classification, IPSS, International Prognostic Scoring System, that take into account the age, constitutional symptoms, hemoglobin, leukocyte, and blood blast. So we can break down the patient into 4 categories, as you can see here: high, intermediate 2, intermediate 1, and low risk. And the median survival range from 2 to more than 14 years. So based on this, we can split the patient into 2 categories: higher risk with the high and intermediate 2, and lower risk, intermediate 1 and low risk. Of course, it was one the old, I would say, classification, but it's still valid right now. So we have DIPSS, which is dynamic because we can assess the patient over time. And then we have DIPS plus, so we can add low platelet count, requiring transfusion, abnormal chromosomes, as you can see here. GIPS, it's really focusing on abnormal chromosome and gene mutations, and MIPS that take into account the whole factors, risk factors. What about mutation status? As you can see here, for CALR, observed in 22 of patients, the patient had better survival than those with the MPL and CHEK2 inhibitor, and the patient, 12% of patient was triple negative, so no JAK2, no MPL, no CALR, so they have the lowest, the shorter survival. And even after transplantations, we can see exactly the same. Actually, it's not specific to myelofibrosis. Unfortunately, even in AML, myelodysplastic syndrome, gene mutations plays a role even after transplantation. So now your patient is fit and the patient is at risk of transformation to AML. So you need to look at transplant-related factors, especially to the donor. If you have a well-matched donor, so it's really a good point to go to transplantation. This is old, 2014, but as you can see here, what you have a matched donor, you have better survival than patient who received partially or mismatched HLA donor. Excuse me. Now, timing of allo. When to do allogeneic transplantation? This is a big question. Here with the Chronic Myelodysplastic Working Party, we worked on this in comparison between patients who underwent allogeneic transplantation compared to patients belonging to the Spanish myelofibrosis registry who did not. It was a very difficult work and very sophisticated statistical analysis to have this work done. And now with this, what we can see here, if you look at the excess mortality in patient aged more than 65 years, so within the 2 or 3 first years, actually allogeneic transplantation represent higher excess mortality than no transplantation, but the curve cross at 3 years, and then you can start looking at the benefit of transplantation. So you need to think about this. So it's not necessarily urgent to transplant the patient right away. So you have 1 or 2 years before deciding, unless you have really a high risk factor for the patients. This is a little bit old too, but very interesting, because when you look at the patient transplanted with lower risk, low risk, or intermediate, no transplantation was better than transplantation. And as you look here, you know, these patients were followed for at least 20, 25, 30 years. So it's a very long period. Patient transplanted with IPSS intermediate 2 or high, of course, transplantation was beneficial for those patients. More recently, in this study, compared upfront allogeneic transplantation versus JAK inhibitors in patients with MDS with DIPS intermediate 1 or higher. So JAK inhibitor gave better results, and in those with DIPS intermediate 1. But when it comes to DIPS intermediate 2 or high transplantation, at the beginning, the difference was not that much, but at the end, you have this plateau with allogeneic transplantation, and without transplantation, the curve is going down. So based on this, we can think this way. You have your patient with confirmed myelofibrosis diagnosis. You do the test to see if the patient is fit for transplantation or not. In fit patients, you have to consider transplantation sooner, right away. In patients with DIPS, higher risk, that to say high or intermediate 2, so you go transplantation. If DIPS it's low, so you need dynamic assessment. If you observe rapid increasing in peripheral blood blast or bone marrow blast, worsening cytopenias, those other symptoms, you have to restage your patient and to go in the loop. For patient with intermediate, so it's difficult to make the decision. So you need additional factors. DIPS, it's not enough to decide to go transplantation or not for those patients. Additional factors, so you can use molecular IPSS, which identify detrimental mutations for myelofibrosis, is XL1, EZH2, SRSF2, IDH12, and U2AF1. And you can use MIPS 70 plus, the second version, which include cytogenetic, etc. So if you have DIPS intermediate 1 and you have inferior karyotype or absence of CALR1 mutation, presence of these detrimental mutations, so transplantation can be indicated. In this case, I think you can use the GIPS classification, which is limited to abnormal chromosome, as you can see here, and somatic mutations. So my second message is DIPS is a dynamic scoring system. You need to assess your patient at regular basis. It's not at weekly or every month, you know, because myelofibrosis is still a chronic disease, but at least 1 or 2 times a year for the patients. Theoretically, allogeneic transplantation is indicated in patients with higher risk myelofibrosis. That's to say DIPS high or intermediate 2. And you need a careful evaluation for patients with lower risk myelofibrosis to decide of the good timing for transplantation if needed, of course. Every time I do presentation on transplantation and myelofibrosis, I have this question from the audience. Do you have something simple to see when to transplant the patient? Because it's still difficult, I would say. This is my own opinion. So if you look at all scoring system we have, it started in 1996 in Lille. Here, I'm very proud to tell you this. And then we have Cervantes, IPSS, Deep Plus, etc. But if you look at all these classifications or scoring system, there is a common denominator, hemoglobin with a threshold of 10 grams per deciliter as a cutoff. This is very important. And if we go back more than 25 years ago, in 1999, the first paper ever in transplantation myelofibrosis was done by my colleague Philippe Guardiola when we were at St. Louis Hospital in Paris. And this is international study, retrospective study at this time. In multivariate analysis, what we found hemoglobin level at transplantation with 10 grams per deciliter as a cutoff. As you can see here, it's really a risk factor. The high risk factor, 8.3, and then grade 3 myelofibrosis, of course. I don't need to talk a lot to convince you that this cutoff, it's really something for allogeneic transplantation. This is patient transplanted with more than 10 grams per deciliter or 100 grams per liter, and this is the other with hemoglobin level below 10. So this is really real cutoff. It was in 1999. But more recently, this international effort between the CIBMTR and the EBMT, so we tried to provide you with a simple prognostic system in patients with myelofibrosis. And as you can see here, we started with the training cohort using the database of CIBMTR with 623 patients. That were matched with validation cohort from the EBMT. As you can see here, we could really break down 3 separate population of the patient or risk population of the patient based just on age, hemoglobin, and donor type. It's really simple. As you can see here, you have the age more than 50, the majority of your patients, and you have this cutoff of 10 grams per deciliter or 100 grams per liter, and then you have the donor, as I said, you have well-matched donor or partially matched or mismatched donor. There is a difference. So my third message, you need a dynamic assessment to those patients. I repeat this, hemoglobin approaching 10 grams is a good point to consider a low and eligible patient with myelofibrosis. When you think about transplantation and you have your patient, fit patient, and you start seeing hemoglobin going down, so this is the time to go to transplantation. Don't let hemoglobin going less than 10 grams per deciliter. However, you have, unfortunately, patient with less than 10 grams per deciliter. At the moment you make the diagnosis. So there is another, you need to use the other classification, of course. How to prepare the patient to transplant? First of all, is there an impact of prior JAK inhibitor therapy for those patients? Can we use JAK inhibitor before going to transplantation? So this study with the chronic malignancy working party. As you can see here, for event-free survival, we have longer event-free survival time in patients who were responsible to ruxolitinib before transplantation. However, patients who failed to ruxolitinib had similar outcome, I would say, and similar event-free survival after transplantation. That's to say, if you use ruxolitinib before, if you have the chance to have your patient responding to this treatment, so it's a good things for them. Otherwise, you are not detrimental for post-transplant outcome, I would say. This is due, I would say, I think this is my own personal opinion, to the massive splenomegaly in patient failing ruxolitinib before transplantation. So what about of spleen size for transplantation, the impact of spleen size? So we did this study too. As you can see here, if you look at this probability of survival, overall survival, so patient transplanted with less than 5 centimeter under the costal margin had longer survival than those who had splenomegaly between 5 to 14 centimeters and more than 15 centimeters. So it's clearly shown that spleen plays a role in post-transplant outcome of these patients. So one can argue saying splenectomy, it's something, it's very complicated operation and can be detrimental and prevent the patient undergoing subsequent transplantation because of complications. So I can understand such a question. So we did in France this study, a comprehensive study. We started with the France Greffe de Moelle. It's really the registry to search a donor for the patient, and we looked all patients registered in this registry with the indication of myelofibrosis. So transplantation centers registered the patient with the indication myelofibrosis, trying to find an unrelated donor for this. We were sure that at this time of registration, there was a real indication for transplantation of those patients. Why we are sure? Because to register your patient, you have to pay something like 1,500 euros to get registered. So you will not play with this. You register your patient when you think there is a need to search for an unrelated donor. So we were sure for the indication, and then with some sophisticated statistic, actually, we matched this with the French Society for Transplantation Cellular Therapy database and the other database in France. And then we did this multi-step study, starting with the registration. We were sure that the patient had an indication for transplantation. Some of them were transplanted without splenectomy. Others died without splenectomy. Some of them were splenectomized. In part were transplanted, and other died before. And as you look at this, it's a very difficult to understand, I would say, but the result, it's clear. Splenectomy before transplantation is not detrimental, does not prevent patient to undergo subsequent transplantation. As you can see here, association between splenectomy and transition to allo or death, transition to allo in those patients splenectomized within less than 4 months, the risks are very high. That's to say, the majority of patients after splenectomy could undergo allogeneic transplantation, and it's still true even after 4 months, but the other ratio, it's less. Transition to death was lower, I would say. So we can offer splenectomy to those patients without any additional risk, I would say, with a reasonable risk for those patients. This is another way to reduce the spleen size with this splenic irradiation for myelofibrosis. This is a retrospective study, I would say, I have to confess, but this is very important because this is the first one. We were supposed to do this within the chronic malignancy working party. I think we are working on this. But if we look at this study, irradiation before transplantation was effective. No effect on hemoglobin, but we observed thrombocytopenias and drop in leukocytes, those patients. Actually, if you decide to go irradiation, so I think you need to do it just before starting the conditioning in the 2 or 3 weeks leading to transplantation, so that you can succeed. You do your irradiation and you start your conditioning and transplantation otherwise. But if you do your irradiation and you wait till 2, 3, 4 months, you will lose the benefits of irradiation. So splenic irradiation, it's another option. To be honest, in my centers, we opted for this option for the patient. Otherwise, we use it to offer splenectomy to all our patients. We will investigate the difference between the two shortly. Within the chronic malignancy working party with Nicola Polivetti, you can see here, we give some recommendation how to deal with splenomegaly. So when you have splenomegaly between more than 5 centimeters or less than 5 below with disease-related symptoms, so we recommend JAK inhibitors for at least 3 months. In patients with less than 5 centimeters of splenomegaly, you can go to transplantation right away. For those with the spleen between 5 to 14 centimeters, so you can consider alternative JAK inhibitors. Nowadays, there are reports on the 2nd generation of JAK inhibitors. You can go for splenectomy or splenic irradiation or clinical trial if you have such a thing. For patients with more than 15 centimeters, I think you need really consider doing something for this massive splenomegaly, especially the same thing, other JAK inhibitors, splenectomy, splenic irradiation, or if you have a clinical trial, go to this because we need really to answer this question for 100%. Meanwhile, this is our recommendation. Now, what conditioning? What about the conditioning? Actually, between RIC and MAC, it's difficult to say, but I think all patients already and those with comorbidity, you go for RIC. For the other, it's MAC. And if there are many studies published with conditioning, as you can see here. So overall survival in years, here you have 5 from 3 to 5 years. It's something really encouraging. Around, I would say, 50, 60, even 67%, 71%, you know, at 5 years. So it's very encouraging. As you look at these conditioning, they are using fludarabine plus melphalan or thiotepa or busulfan, an alkylating agent. So this is slide. It's really a common sense. So when you have to select your donor, the best choice is matched related, then matched unrelated, and haplo or mismatched unrelated, and unrelated cord blood. There are some report on this. Of course, the best donor for myelofibrosis so far, it's matched related donor. For the conditioning, it's common sense too. So You look at the age, the fitness, low, high, and the intensity, or MAC, according to what we have here. So usually you have fludarabine based with alkylating agent, with or without thiotypa, which is another alkylating agent, of course, and investigation of new combinations. Why not? So the alkylating agent, it's melphalan, triosulfan, busulfan, and thiotypa, of course. Now, what about post-transplantation? Actually, as I said at the beginning, this is a very difficult disease because cytopenias occurs after transplantation, and we don't know what to do with this. It can be relapse, poor graft functions, or graft failure, etc., or other, I would say, other factors. So I recommend you to read this paper. So if you have cytopenias following allo for myelofibrosis, first of all, you look at other factors. You need to rule out all these factors. If yes, you give the treatment. For instance, if you have, let's say, vitamin deficiency, etc., so you treat them. Otherwise, you go to myeloid chimerism. When you have full donor myeloid chimerism and cytopenias, persistent cytopenias, you are facing a poor graft function. Otherwise, you have mixed or full recipient chimerism, so you need to look at the factor that can give you orientation towards relapse or graft failure, you know. And in this paper, we give many recommendations how to deal with those patients with DLI, second allogeneic transplantation, or how to manage immunosuppressive, etc., etc. I think it's something important. So for the conclusion, myelofibrosis is a chronic myeloid malignancy. No rush. We have time to organize the transplantation. You need really to think about your patient. Patient's monitoring must be dynamic, as I said, and treatments will be given accordingly. New drugs are under investigation to alleviate myelofibrosis-related symptoms and complications, but so far there is no cure without outside allogeneic transplantation. So allogeneic transplantation is still the only curative option for the time being. Care for patient and disease assessments are needed, patient physical conditions, disease characteristics, and transplantation modalities. Keep in mind, hemoglobin level at the threshold of 10 grams per deciliter is a good threshold. If your patient candidate to allo had hemoglobin over 10, don't let them go down. Try to do transplantation while the hemoglobin is more than 10 grams per deciliter. Thank you very much. I would be happy to have your questions. I have here some question, Paula Heller. So the first question regarding how to choose a donor. It's really difficult between when you have, in the absence of matched sibling on a related donor, which is the balance between haploidentical or mismatched unrelated. I don't know. For me, we decide to go to haplo when it's possible, but sometimes, you know, it's difficult because if you go for a sibling, they are old and you cannot harvest them. And 9 out of 10, why not? We have an ongoing study comparing haplo with 9 out of 10 or 7 out of 8 with the post-sci in both sides, because we don't know the difference between the two can be really related to the type of donor or the immunosuppressive treatment post-transplant. So for the two, I think haplo or mismatched unrelated, it's okay, provided you use post-sci after. Other question: how do you sequence the newer agents such as pacritinib, fedratinib, emritinib, prior transplant? Okay, so how do you sequence the newer agents such as pacritinib, fedratinib, melotinib, or ruxolitinib prior to transplant? I think ruxolitinib is the first line, and you can use a second line, as I mentioned. If you have anemia, momelotinib can be proposed, fedratinib second, and otherwise you cannot sequence all of them because you are wasting your time. Because if you have failure to ruxo, for instance, so you try second generation, one of them, and if you succeed, it's okay, you go transplantation, but otherwise you go to transplantation anyway, I would say. So when do you need to discontinue this agent before transplant? So for ruxolitinib, we continue ruxolitinib during the conditioning, and for other colleagues, they can go up to recovery, and there is a report, there is no detrimental effect, and maybe some beneficial effect. I cannot say this with 100% sure, but what I can recommend you, don't stop them before starting your conditioning, because you can have this flare, which is not a good idea to stop them before. So you continue the earliest at the end of the conditioning, I would say, and you can continue them. It's not a problem. This is another question with an Manuel Crisan. It's important. Would you consider allotransplantation in a young patient and fit, of course, JAK2 positive primary myelofibrosis with intermediate 1 DIPS score with only progressive leukocytosis during ruxolitinib and fedratinib? So a young patient, how young is are they? Up to age of 40 or 45, I think, yes, I can consider this, because this is a good time, but there is no rush. No rush. You can organize, and especially if you have a well-matched donor for those patients. Yes, age, it's very difficult with JAK2. You have a median survival more than 4 or 5 years, but in young patients, we have always this dilemma. If we wait a lot, so we will lose the patient. Otherwise, if you do it early, we can't be toxic, etc. So I would say definitely yes, there is no rush. And I look at the hemoglobin level, and when I see decreasing outside toxicity of ruxolitinib, for instance, I start seriously discussing allogeneic transplantation. Remaining events in the right part of the survival curve, where we see advantage of deep center high, are quite limited to be so sure. Yes, for the curve I presented, but there are many other studies with this sustained survival on those patients, So you're right, because I would have chosen another study maybe for this. Hemoglobin less harms, but at the same time was shown as most powerful good predictor of survival over an event in early scores, or other can think of avoiding. So I didn't understand this question, Janvier or Khafir. So hemoglobin less than 10 grams, it's a risk factor with or without allogeneic transplantation anyway, because this is a risk factor in all scoring system, I would say. So Sometimes we have to transplant patient with less than 10 grams per deciliters. And we need to look at this benefit-risk balance, of course. As I said at the beginning, this is really one of the most difficult diseases to transplant. Thank you, Arnon. Any recommendation for type of graft and cell dose? Thank you for this question. It's excellent. Type of graft, that's to say bone marrow versus peripheral blood. Actually, a few years ago, we thought that peripheral blood was something better than bone marrow for patients with myelofibrosis because we need a higher number of lymphocytes, etc. I'm not sure that we had a firm, we had really good studies with a firm conclusion for this. However, what happened? The vast majority of centers, including mine, we switched to peripheral blood. And now it's really difficult, even not impossible, to do this comparison, bone marrow and peripheral blood for this. So what about cell dose? We worked on this. Actually, the dose of CD34, the higher dose, especially in sibling transplantation, was associated with better survival. You can see this. It's Thomas Gross within the Chronic Malignancy Working Party, a very nice paper on this. Any recommendation by prophylaxis, PTCI versus calcium inhibitors? It depends. On the donor type. When you have well matched, I don't know really. We have prospective studies comparing post-Cy versus calcium inhibitors after transplantation. For my center, we still with the old-fashioned cyclosporine and methotrexate. But as I said, for patients with haplo or unrelated mismatch, 9 out of 10 or 7 out of 8, I think post-Cy can be a good option this way. Gonzalo Ferrini, do you use JAK2 dosage to evaluate disease after allo? How do you do? We don't have quantitative for JAK2 dosage, but we look if we have JAK2 or not, because sometimes you can see disappearing of JAK2 after transplantation, and sometimes you have reappearance of JAK2 while the patient was in molecular complete remission. And we look at the other gene mutations if we had any before transplantation. This is an excellent question, though. Anna Manuela, the question, 55 years. For your patients now, 55 years, no. It's young, but not that young, because more than 50, as you could see in the simple international prognostic factor, more than 5, you start having some problems with this. So I think for your patients, look carefully to the hemoglobin and try to prepare the transplantation for them. But it's very difficult within a webinar to give you a clear decision. I'm so sorry. I need to see really the whole file for the patients and to discuss in depth every single characteristic to the patient, disease, and transplantation. So sorry, I'm really sorry. I cannot, I can only give you some general ideas, 55 years for our simple scoring system. It's 1 point. So it start to impact outcome of transplantation. But once again, I would be happy if you send me the whole story of your patient to help you if I can. When you are using JAK preconditioning and post-transplant, would you consider lower dose of JAK like 5 milligram? Thank you. This is very interesting and difficult question. Actually, I don't lower JAK2 just before, but because I need to lower it, you know. First of all, we look at the tolerance of the patients with this dose. And if you are convinced that you need to continue JAK inhibitor even after conditioning and up to hematological recovery, while lowering it, but I think you cannot do everything with 20 milligrams twice a day. It's really high. Carlos Vallejo, thank you. 2 queries. In patient in which you decide to use pre-radiation, how many grays in 1 or more fraction? Thank you for this. I can recommend you to read the paper I presented from the Chronic Malignancies Working Party, because we described in a supplement to this article the whole way to irradiate the patient, how to design the field of irradiation, what dose and fraction it, etc. And you can send it to your radiotherapeutic, so what I did in my center, I give them the article and saying you need to follow this method, something very very nice and very clear. So just roughly, I would say we go for 10 grays and fraction it or in 5 days, So, but if you need more explanation, go to this paper from the Chronic Malignancy Working Party. In patient in which you decide to use flubu-based conditioning, do you think that using IV busulfan is an equal approach? At 7.5 milligram total dose, milligram per kilo, is equilibrated approach? I don't know, because we have our standard, 3.2 milligram per kilo, 2 times, 3 times, or 4 times. So 7.2, it's really in middle of nowhere. So we have FB2, so it's 6.6 milligram per kilo, and 3, it's 9, no, it's 653, 9.3, and 12 0.6 milligram per kilo, but 7.5 milligram per kilo, I don't know. We have a lot of problem with the conditionings because of the heterogeneity, and every single center is using their own conditioning regimen and dosage, etc. Believe me, it doesn't matter, between 6.5 or 7.5, because there are a lot of other factors that are involved in this. For me, I try to do the standard doses, even though if I'm not 100% convinced. Why I do this? Just to be able at the end to compare the results, because in allogeneic transplantation you have many factors such as the patients, the disease, and transplantation modality, etc. I'm trying to harmonize. By the way, I'm the chair of Practice Harmonization and Guidelines Committee, so I'm struggling to harmonize, the way to do this. And for me, the difference will be very slight. Would you consider allotransplant in a 45 years old patient with a DIPSI score intermediate as a preventive measure if you do not have access to molecular markers? Yes, but if you don't have access to molecular markers, try to monitor them closely and look at the hemoglobin and modification and the spleen size, etc., to decide with the perfect timing to do this. Sorry, 8 milligram, 3.2. Yes, actually, we use this in patient aged more than 60 years old because, or patient with comorbidities. 2.5 days of 3.2. So why 2.5 days? I don't know. The same. You can use 2 days, 3 days, or 4 days, and you can do 2 days with Theotipa. Probably, but this I cannot assure this. Adding Theotipa can be helpful. I don't know. You have also thiosulfan, which demonstrated some efficacy with less toxicity. But 2.5 days is in between the two. I'm really sorry, Carlos. Sorry. So there is no additional question. Thank you very much. I really appreciate these questions. They are very important and informative and demonstrate that this transplantation in this disease is very difficult for many people. Hopefully, I could give you some insight, helping you managing your patient candidate to transplantation. Thank you very much, and thank you for the International Academy for Clinical Hematology, because as I mentioned, this is a very, very nice initiative. Thank you very much.